Well, thank you for inviting Interlink to come and speak today. I like to speak to large populations of employers and brokers together, and this is a very great venue to share our ideas with. I've been invited today to come and talk to you about two programs, and I have 45 minutes, and I think that I just lost 5, so I'm going to kind of move us along today. Just for an update, a little bit about Interlink. We were founded 21 years ago. And for 21 years, we've been your Centers of Excellence partner. We're really well known in our space for working with very low frequency, high cost medical procedures. We offer 7 different Centers of Excellence programs, and we're really well known for our educational capabilities. So that's just a little bit about us. But the 2 programs I'm going to talk to you today about are our transplant care and our cancer care. Now, when we use the word program, we use it in a specific way. And what that means is a program comes to you with Affordable Care Act reviewed benefit plan language and 1 or more Centers of Excellence programs. So we're going to start off by talking about transplant care. So I look around and I see lots of blue lanyards out there. And I ask myself, what is today's self-funded employer really looking for? Well, we're in the world of value-based purchasing. And what you people want, you want programs that are unique and new. Because some of the stuff that we've used in the past simply has not performed or become null. You want best outcome care, you want low and predictable prices, and you'd like to implement programs that are good for the company and the plan, but you also want programs that you don't take too much choice away from your members. So in the world of transplantation, this is actually easier than you think. I remember when value-based purchasing was first coming up 3 or 4 years ago at conferences like this, and you guys wanted the care done at the right time, best outcomes for a low and predictable price. In the transplant world, transplant centers are required to submit their transplant data each and every year. It goes into one single organization. And to make sure that it's even clean, it's sent off to the University of Michigan to be risk adjusted for the populations that they serve. So if we can't do value-based purchasing in the transplant world, it simply can't be done. So when I start my talk about transplantation, I want to start talking about what is the correct measure of performance for a plan like this. What is success? You heard Adam yesterday saying PPOs are dead. Well, what we really are focusing on now is what's called net payable. This is the check that the plan actually writes out the door. We're not looking so much at discounts. And sometimes somebody will walk up to me and they'll say, John, Interlink rocked it last year. You saved us 55% on our transplant episodes last year. And I'm going to take that compliment and I'll shake that hand. But when I leave, I make a mental note to get a hold of my marketing team and sales team, to get a hold of that client and to really re-educate them about what success is. Because it could be like a % discount focused client. This case could have gone just like this. The patient needed a liver transplant, so they went to the closest transplant center to where they live. Because about 80% of your candidates, that's how they make their decision. A multi-million-dollar plan decision made because it's the closest place to where they live. They went for the transplant and didn't grow all that well. They accumulated $1.5 million in transplant charges, paid under a case rate at $600,000. That's your 60% discount. But what a lot of plans are doing now is that transplant frequency has been pretty much flat for the last 15 years. It's 15 transplants per 100,000 members. So a lot of plans are taking more of an offensive approach. We're going to take this benefit and we're going to incent our members to go to a Centers of Excellence programs. And their focus now is on net payable. And in some of the models that we're going to talk about today, you're going to see here a net payable focus, a goal to be determined to be a gold level provider, contract performance, net payable for the transplant episode, which includes hospital, organ, and professional, had to be $185,000 or less. So what we're moving from is a defensive strategy, something We work with Cypress Benefit Administrators, and when a transplant becomes known, they're going to contact us, and we're going to get the deepest discount we can for the plan. Okay? A lot of that's done through your reinsurance carriers, but the last one is an offensive strategy. And an offensive strategy means that the plan is accepted that they're going to handle the transplant risk, and they're putting in plan benefit plan language to manage it. And your reinsurance carriers and a lot of MGUs incent plans for putting in an offensive strategy. Now, a lot of our products are distributed through brokers and through TPAs. And so we created for them a tool, and it's just a graphical representation of the range of transplant options that are available today. If you look at the inside of the bottom axis, we have any provider. In other words, the plan document is silent. Your people can go to any transplant center that they so choose, then there is no incentive to do it otherwise. If you go straight up from there, plan protection is low, and plan member choice perhaps high or overvalued in that model. So what we tend to see is we see people, a lot of plans go from clear to the left, go all the way to the right. In other words, they go to a carve-out plan where they pay a premium to another insurer to manage that risk for them. In that model, we have very low member choice, and you've got very high plan protection, but it's paid for at a premium. We believe is that there is choice, and that choice is going to be right here in the middle. And this is called the Transplant Elite program. And we're going to see some of the plan documents in here move from any provider more towards the center part. And I know that there's some people in this audience that are in a carve-out that are probably going to move more to the center. Because like most things in life, is that probably the most viable solution is between two polar extremes. For the last 21 years, we've had medical teams. And these medical teams scour transplant outcome information to identify those transplant programs and centers that your members want to go to, the best performing. But when we started talking about value-based purchasing, and your guys want to, your employers and the brokers and the TPAs wanting to narrow, we began to build a predictive model. And that model takes into consideration time and net payables, which are the three variables of value-based purchasing. So we're going to start by examining the first element, which is the wait time. If you can manage time in transplants, this is a huge opportunity for your plan. If you look at a carve-out or just any plan, you're going to have the evaluation, which is that small blue square. And then patients are going to wait and wait and wait. And as their condition becomes more dire, they eventually will transplant, where the next blue curve happens. And then they will, excuse me, then once they transplant, it's just 1 year post. That's what most transplant case rate contracts involve. What you can do is you can manage this for your advantage and your patients. So what are the advantages of managing this? Well, one is that pre-transplant charges can be minimized for the plan, and your patients are going to transplant at a much healthier time. And how we get there is not rocket science. There are 11 UNOS regions in the United States. The federal government realized there was going to be an organ shortage a long time ago. And so they broke up regional collections into regions. And inside each one of these UNOS regions, they are responsible for collecting organs, distributing them within their region, and those that are left over could transplant nationally. So if you look at a liver transplant, for an example, what the UNOS data would say, we're looking at wait time. This is median in months. We're looking at transplantable MELD score, the MELD score at the time of transplant. And then our optimal MELD score, this is the optimal time, is for patients with a MELD score between 15 and 24. So let's say that we had a patient at the Boston area. They're going to wait, on average, 41 months for their transplant. And they're going to transplant with an average transplantable MELD score of 29, outside of our range. But let's say that they have family and relatives in other markets. Well, if you look at Region 5, which is the California areas, we're talking an average transplantable score of 32, which is near death, and they will wait for 72 months for their transplant. But if they're working with people who are in the know, they're probably going to be focusing on region 3, with an average wait time of 2.2 months, with an average transplantable MELD score of 22. So what does this mean for you as consultants and you as plan administrators? Let's say we had 2 patients. Both of our patients resided in the Boston area, and both of them needed a liver transplant on the very same day. Our blue line recipient, he's in an undirected plan. He's going to get his evaluation really quickly, but he will wait many months for his transplant. And you can look at the cost curve that he will incur as he waits. A red line recipient, she is in a narrowed plan, a performance plan. It takes another couple weeks to set this up. But she transplants very quickly. And she transplants when she's still healthy. So what does this mean, to recap? Our blue line recipient waited 17 months for a transplant and incurred $550,000 in pre-transplant charges, which is fairly average for that time of wait. He transplanted when he was really sick, and he has poor outcomes. Our red line recipient waited 4 months, incurred $95,000 in pre-transplant charges, and was relatively healthy at transplant. So if you look at managing in the value-based care model about time, that's how you would manage time in the transplant world. Now we're going to look at the other 2 elements. We're going to look at best outcomes, and we're going to look at low and predictable net payable. We collect 120 pieces of outcome information per liver program per year. And when we decided to build the predictive model, we identified the 25 most telling outcomes about how a transplant team is performing right now. And then we weighted those values to predict into the future. And our predictive modeling program enables plans to develop networks based on providers predicted to be transplanting at peak performance in the upcoming 6 to 12 months. So say that you have Delta Airlines, some broker in here, and you say, Interlink, we would like to do a customized program. So what we would do is we would sort our database, and we would look at liver transplants, for an example, and we would sort for livers. And the second thing we would do is we would sort for best outcome. And the Ochsner Clinic, with a cumulative score of 174.4, is the top performing liver transplant program in the United States today. And then we would pair that with best outcomes, financial outcomes. And we have the Ochsner Clinic with a gold level contract, net payable at $185,000 or less, with the best outcomes. So sometimes some of our clients will build customized programs based on value-based principles. But a lot of people came to us and said, John, we do not want all of our clients to sit down and to create their own customized network. It's just not practical. We would like the Interlink's concierge shoppers to come through and develop a network that would be applicable for all of our clients, a narrowed network that you manage. And we manage that under the name of Transplant Elite for our clients. And what this is an optimized network that's built out of our larger Centers of Excellence program. There's elevated criteria for participation, and we do adjust it annually. So just how narrowed is this? Well, in the United States today, there are 300 transplant programs across the United States, offering nearly 1,200 different programs. If you apply our Centers of Excellence criteria, we narrow it to 82 centers, or 41% of the providers. But when we apply Transplant Elite criteria, we narrow it to 48 centers and 109 programs in total. So the next logical question you probably are asking, is this too narrow? Are we narrowing this benefit too much? And we would say no. And we're going to explain to you how we came to what we came to. We broke the United States into population regions, and we have 6 regions of the United States. And this is the liver transplant map that your client, your patients, your members, your employers would see. And you would say, oh boy, I don't see anything in Idaho, Montana, North and South Dakota. There's a lot of green space in this, John. But let's do some takeaways here. Let's take away states that do not even host a transplant center, let alone a liver program. And we'll take those out first. Now we're going to take away states that have a liver transplant program that didn't even meet the criteria for our widest network. And now I'm going to take away centers that are in our transplant network that may be having liver transplant issues now, so we're going to take those out. And when you look at a map like this, say you have a client in Nevada, they're completely surrounded by transplant centers that are transplanting right now at peak performance. And rather than look at it as we're severely limiting patient choice, we prefer to look at it as improving member decision quality, because they simply don't have the data really to make that decision. They could choose anyone they want to go to, but this is the Transplant Elite Network. So what does it take to put this in? It doesn't cost anything. This is a free program. We give you the benefit plan language, and you pay for it as you use it. And the right-hand side is the benefit plan language, and there are 5 options. And this has been reviewed by the FIA group and Groom Law. And you have 5 choices you could make, and then the left-hand side are the choices. Explains why we made the decisions the way that we made them, and you and your plan can make the choices that they best see fit. So kind of wrap up the transplant side. So what are we getting here? Well, you get member comparison education tools beyond what they could ever imagine. Transplant data, there's so much data available, and it's sliced so thinly that patients have a hard time making a decision. It comes with the benefit plan language and guides. We'll educate nurses. We're educating Cypress Benefit Administrators, nurses. We have been for years. And it comes with up to 3 broker planning sessions with Interlink account management and our legal teams. Now you could take this network and the benefit plan language, and you have 3 different network options that you could pair it with. You've got your transplant centers of excellence, which is outcomes narrowed. That's 82 centers. You can go transplant elite, narrow it to 46. But the largest employers narrow very narrow. They will narrow it down to the top 5 or 6 transplant programs for each transplant type. So you have options when you go to this program. So now we're going to make the shift. How many people out there would say that cancer is probably one of your number 1 plan problems? A lot. There's not been a lot of development in this area because the current models that we use, we keep using them. But new tools are becoming available. And Interlink was invited into this decision process, into the cancer program. We have relationships with centers that are very hard to get to know, decades to cultivate. MD Anderson, Memorial Sloan Kettering, Dana-Farber, those quality programs. And our clients said, Interlink, can you get involved? So the rest of our conversation, our time, is going to be invested to learn a little bit more about the cancer care program. I think you're really going to like what you see. I'd like to say that we addressed all of the value-based purchasing parts of it, the right time and the right for low and predictable price. But in cancer, that simply doesn't exist. So when you look at cancer, you got to say from the very beginning, this affects plans, providers are involved in this, and so are patients. When you look at the plan's perspective, cancer costs have been rising at 20% a year, while plan costs have been rising only 6 to 8. And if you're with Cypress, you're doing much better than that. And on autopilot. Drug costs are expected to double, and we identify cancer patients simply too late. And then lastly, there's overutilization. So what do providers add to this problem? Well, there's excess billing, new drugs, the profit motive, low surgical volumes. I live in Hillsboro, Oregon. I've lived there my whole life. My hair cutter's there, my dentist is there, my primary care doctor, but there's certain surgical procedures that my surgical center is actually MD Anderson. And what do patients bring? unrealistic expectations. If you're diagnosed with stage 4 cancer of any type, that's typically terminal. But I don't think patients look at terminal anymore. That's not part of their vocabulary. They're making decisions at the worst time of their life with information that they don't always have. It brings a lot of patient anxiety. And there's also clinical trial care. And this is for, long shot care for people. And they all want access to this, and the Affordable Care Act made it so. So when you put it all together, how does a plan manage that? And how does Interlink put together any kind of a management program to deal with that? But I'm here to say that the number one problem is this. 80% of employer plan documents don't even have a cancer subsection anymore. Never had it. So you're managing your number one risk without benefit plan language to drive it. I think Adam and I would agree that the employer plan documents of the future are going to be more targeted for targeted procedures. So when we developed our cancer product, this is where we started. We started with the benefit plan language. This is a document that anybody in this room could download for free. It's an Employer's Guide to Treatment and Prevention, tool number 2, Plan Design and Assessment tool. This was developed in conjunction between the National Business Group on Health, the nation's largest employers, and a company called NCCN on a grant from Genentech. Now, how many people understand when I say NCCN, what this means? Anybody? Okay, a couple, good. The NCCN is an association of some of the nation's most prestigious cancer centers. And they wanted to create an organization where they could come together to share their outcome information. So it comes under the name of NCCN, or National Comprehensive Cancer Network. It's $1 million to join and $1 million a year. So this is where some of your plan dollars are going, is to fund this. But for each and every cancer type, there is a committee. And each one of the 28 committee institutions that participate have a member on that committee. And what they do is they look at all of the clinical trial data, all of the outcome data that they have, and they share it amongst each other. And they write guidelines for cancer treatment that are published on the web under the name of NCCN guidelines. Now, these are used nationally and internationally. So the benefit plan language story starts there. NCCN, representative, and the National Business Group on Health said, let's create a template for writing cancer benefit plan language. So we accepted their challenge, and we drafted that. We took this 85-page document, distilled it down to 4 pages. This could be inserted into your plan documents. It comes for free from Interlink as part of the program. It's been externally reviewed. We have our own attorneys, but it was externally reviewed a couple times by Groom Law. And I come to these things, and I purchase Adam Russo's services as well. And so the FIA group reviewed it this year. It comes with benefit plan language, and it accesses 3 centers of excellence networks that are defined inside this benefit booklet. And the largest job that we had was to operationalize these provisions, because most of the time, it had never been done before. With benefit plan language in Spot, what we're able to do is to break a cycle that happens with everybody's health plans. And the cycle starts with John Van Dyke getting a diagnosis. And what happens is, first you hear about it as a diagnosis. And what patients can go into is a treatment decision window that could last 2 hours or 3 or 4 weeks. This is where the doctor is planning with the patient about what they're going to do. And the first that the plan's going to hear about it most of the time is through treatment authorization. The plans are all made, and we have 24 hours to make a decision whether this is a covered benefit or not. So they provide treatment. And then once somebody's in a treatment window, cancer care, our medical directors, IMRs, nobody's going to stop that treatment regimen, okay, until they're completed. And then our influence time can happen afterwards. Some plans, that TPAs, in the South that I talk to, certainly not Cypress Benefit Administrators. They learn about their cancer patients when claims are received. But we believe that if you drop in benefit plan language and put stickers on cards for people to call us as they're diagnosed, right after they're diagnosed, there is a small window of influence that we could make. And with this, we call this the optimal window for change. The plan language we're giving you creates that opportunity for you. So what are the tools that we have to design to impact that influence points? It all starts with benefit plan language. You have to start there, which requires people to call the cancer center triage center at diagnosis. Our people are talking to your patients, your members, your employees on the worst day of their life. But we're gathering treatment information and diagnostic information. And what we're going to do is we're going to take your population and we're going to break it into 3 different groups. Some of them are going to go into our guideline management program, because guidelines is the future for an employer health plan. Somebody's off guideline, it costs you significantly more. Some of them are going to be transferred immediately to a COE access nurse. Going back to John Van Dyke in Hillsboro, Oregon, I'll say, hey, I've got a complicated neck surgery that they want to perform this week on me. And this nurse is going to say, well, John, I know that your hair cutter is in Hillsboro. I know your business is in Hillsboro. But this is not a spot that you want to go and to have your complicated neck surgery. Your plan is put in spot things for you to go to a centers of excellence for an evaluation and perhaps treatment. The surgical volume in the community is simply too low for it to happen. And that's the COE access program. Some are going to go into case management programs. Some are going to go into a clinical trial centers of excellence network created for this program. Everybody's going to go through medical concordance. This is a process. We do not certify care at Cancer Care. What we tell the plan is this person getting guideline care and controlling, recommending benefit payment levels at that. And then lastly, is your patients are going to be treated. Seems like kind of a lengthy process, but if we do our job right, it's all done before treatment authorization even occurs. And you can see where with cancer, this is vitally important that work happen immediately. And it's a combination of a lot of things that we do that make it successful. So how are we breaking up your groups? And we thought, well, actually in the employer's guide, it says if you're going to manage cancer, you have to manage the entire population, right? So when you think about that, that makes a lot of sense. But we couldn't charge to micromanage each and every cancer patient. So we went to our medical advisory panel, and we asked them for some guidance. How should we break this up? Say that the cancer world is this big. The part of that world that we're most familiar with in this room is that top 15%. These are the people with severe, late-stage diagnosis or cancers. And these are people that we commonly know as case management. With this group, we're going to give them full case management support, COE access consultations, clinical trial and pathology or diagnostic COE, which is our second opinion program. The medical advisory panel said, the next logical break for you would be systemic treatments or not systemic treatments, chemotherapy. So 25% of the phone calls we're going to take are from your cancer members that are calling up, that have cancer diagnosis, that are going to be receiving some sort of radiation or surgical procedure. And we're going to collect their information, and we're going to send them documents that say, if at any point they start doing systemic treatments, you need to recontact the cancer care program. But the biggest gain that you are going to get is this 60% in the middle. These 60% are getting complex cancer treatments in the community setting, pretty much currently unmonitored. And we have McKesson Clear Value Pathways, NCCN to back us up. We have COE Access, our second opinion network we're going to run with them, pathology diagnostic, and then Cancer Care One, or they have nurse access. They could talk to nurses. So we kind of look at your entire population. And the biggest problem that almost all health plans have is to get access to that 60% in a timely way to influence care. Now we're going to talk a little bit about McKesson Specialty Health. McKesson Specialty Health, they own 350 oncology practices in the United States. And with the Affordable Care Act, physicians are going to be put at risk for the decisions that they make, which is what everybody in this room has always wanted, right? Not fee for service. We want that physician to take responsibility for their decisions. So McKesson Specialty Health medical directors started meeting once again with NCCN, and they said, it is our vision and our view that not all pathways are the same. And we would like to create a decision tool that our physicians can use in their practices about making treatment decisions based on outcomes and predicted costs, which is the value-based things that you seek. And so they went through it, and Interlink purchased this, and we ported it into this industry. We're using it. I think McKesson Specialty Health doctors make 93% of their decisions using this software. And if you look down the left-hand side of it, what this software platform requires are what they call clinical facts. And when somebody's at the end of a treatment process or just newly diagnosed, they're going to run a series of tests. And in this program, they're called clinical facts. And this software program requires up to somewhere between 3 and 12 clinical facts per diagnosis, and it varies by diagnosis. You enter it in there, and then you would see the table produced next to it. So McKesson was hoping that, if you look at the table, the treatment options are names that every physician is accustomed to. And they would identify those treatment pathways that are value pathways. And what the medical directors were hoping is that their physicians would follow this kind of decision-making process. 1, it's a clear value pathway. 2, it's an NCCN guideline. Number 3, the number 1 that's circled, means that a number 1 from a committee means that the committee members who evaluated the guideline were unanimous in their thinking that this was the optimal treatment program. We have hospitalization risks, vomiting risks are low and moderate, and risk of infections low. And if they wanted to know, and actually, since they're buying it, they click on that upper left-hand circle, the financial estimate, and this gives that doctor the estimate of the drugs and biologics, the cost of what Medicare would reimburse them for that. So when they have to buy them themselves, that's what they're looking at. This has been incorporated into the cancer care program. When somebody calls and they're receiving treatment in the field, or in the community setting, we would call that, we're sharing this information on your behalf with that doctor. And what we've done is we've taken that base benefit plan language that we started from, and we've added in an additional tier. And if that physician will participate with us and share with us the clinical facts during decision-making processes, your plans, this broker group, you want to reward them for that, because that's the best care that you're going to find. Now, there's 2 ways of looking at this graph. You can say, well, the average treatment per course of care in the United States is about $54,000. And if they're on an NCCN guideline, it's a 35% reduction. But the reality of it is, it's actually the inverse. If somebody isn't on the NCCN guideline, then it costs the plan significantly more. And then if you put Clear Value Plus program in it, it reduces it by 50%. This is what the benefit plan language looks like. You'll see NCCN in there, because everybody here is covered under our licensing agreement automatically when you put this program in. And you see networks get progressively higher as you go to the left. This is what we're offering your members: full access, partial access. You can be treated in your own community. Just go to a Centers of Excellence for an evaluation, or they can get 100% benefits by following a clear value pathway. This is the medical concordance process that we run. So you and your teams will be able to see exactly at what point did your people meet medical concordance. And then lastly, this is the return on investment chart that we're running. As brokers and consultants, I know you're interested in return on investment. But we're doing things that nobody's ever done before. But if you gave us $1, this is how we think that we're going to do this. You have 65 cents of it, we're going to get it 9 to 1, just trying to keep people on a guideline. Pathology, if we can treat somebody from getting the wrong care, that is the biggest return for the plan in totality. Centers of Excellence, networks, and clinical trial management. So hopefully in a year or two, I'll be able to come back and to say 20 to 1. Today, we're not in that position. So all of this starts with intent to install documents. All we need is 4 pieces of information. And this works in your advantage for 4 reasons. One is it's a confirmation to those reinsurance carriers and MGUs that are offering incentives to put it in, that this is what the plan's going to be doing, and they're going to reward you for that offensive approach. 2, for underwriters that are unfamiliar with the program, it lists out all the offensive things that the plan is doing. And then lastly, it informs Interlink of what we're doing. I want to thank you for your time. I know your time is valuable, and I appreciate Tom for doing it, so thanks.